Welcome. Welcome to the CHEST webinar, Connecting COPD Heterogeneity to Action, from Biomarkers to Biologic Therapy Decisions. My name is David Menino. I'm a professor of medicine at the University of Kentucky in Lexington, Kentucky, and also Chief Medical Officer at the COPD Foundation. And my co-presenter today is Dr. Meredith McCormick, who is a professor of medicine at Johns Hopkins University in Baltimore and also the director of the Division of Pulmonary and Critical Care Medicine. During the webinar today, you'll have opportunity to ask questions. And to do this, we ask that you actually use the question and answer function that you'll find on your screen. And with that, we will get started. So go on to our next slide. These are my disclosures that cover the last 24 months. And if we go on to the next slide, these are the disclosures for Dr. McCormick. And we are going to start with a patient. I think all good educational activities should start with a patient in mind. And this is our patient, Martha, who could be a typical patient that shows up in my or Dr. McCormick's clinic, who's in her mid-60s with a smoking history, who has stopped smoking. And she presents for evaluation of chronic cough. Next slide. And these are the objectives that we'll be going over today. I'll be handling the first one. Next slide. Most of you should be familiar with GOLD, the Global Initiative for Chronic Obstructive Lung Disease. That has come up with a strategy for both the diagnosis and treatment of COPD. That really ranges from that covers every component of how we think about COPD. And of course, critical to the diagnosis of COPD is establishing what a person's lung function is like. And this is the diagram from the current GOLD teaching set that looks at how one determines the presence of spirometric obstruction using spirometry. And this is in fact it would be a spirometry on a patient like Martha that looks at pre and post bronchodilator lung function impairment. And this actually includes both the percentage predicted that I think most clinicians are familiar with, but also includes Z-scores, which is a more contemporary means of determining the presence of obstruction. And you can see by looking at the blue line, which is pre-bronchodilator lung function, and the red line post-bronchodilator, she meets obstructive criteria, both pre and post-bronchodilator, and in this scenario also has a significant response to bronchodilators, in that she had improved. She had 29% absolute improvement. And if you actually look at the numbers, about a 16% relative improvement in her FEV1 from pre to post bronchodilator. So would meet criteria for post bronchodilator obstruction, and also would meet criteria for a significant bronchodilator response, although she remains obstructed post bronchodilator. And if one looks for the grading of COPD, again, based on GOLD criteria, she would qualify as moderate COPD, in that her FEV1 post-bronchodilator was 70%. Next slide. So how does then one characterize? We've gone from using, back, I guess, 15 or so years ago, we would just grade the severity of COPD based on lung function impairment. And again, 10 or so years ago back, we switched to what was called the GOLD box, which in its original format was A, B, C, D, and now is A, B, E. which is, and this was actually modified in the most recent gold revision that was released in November of this year. Previously, one needed two or more moderate or one severe exacerbation to put you up into the E category. And with this most recent revision, one moderate exacerbation, or of course one severe exacerbation, will put you in the E category. And this is important because, and this is a rationale for more intense therapy, was our goal in COPD is really to eliminate exacerbations, and to the best that we can. And there's still the A and B category down below, and the difference between A and B is based on the presence of symptomatology, which can be assessed either using a dyspnea scale such as the MMRC or a symptom scale, which the chronic airways assessment test, previously known as the COPD assessment test, or CAT, is used for that. And this, in fact, is a depiction of the CAT. And now at the University of Kentucky, this is actually part of our electronic medical record now, that patients who come in with either diagnosed or suspected COPD are asked to complete this before they show up in our clinic. So I actually have a CAT score on all my patients before I even see them. But as you can see, the scale goes from 0 to 40, and any CAT score above 10 is considered symptomatic enough to consider more advanced therapy that would put them in a B category or higher. Next slide. So in the case of our patient Martha, we now know that she's in gold 2 spirometric staging, and based on her symptom score, she would be in B category, so would qualify again for therapy based on that. And if we go to the current recommended therapy, and this is for initial therapy. Now granted, in my clinic at the University of Kentucky, it's very unusual for a patient to come to me that is completely naive to any therapy, because typically they're being referred. But certainly in the venue of primary care, this can happen frequently. So the recommended initial therapy in a patient that is in Group B would be a combination dual bronchodilator, LABA and LAMA, and as is noted with the little asterisk down the bottom. Although these therapies can be given in separate inhalers, there are several options where they can be given in a single inhaler, and these are typically easier for patients to use. And there are lots of inhaler options. This is actually similar to a card that we have in all of our clinic rooms, because again, most patients coming to me have been on therapy, and for most patients, when I ask them, what inhaler are you on? The typical response I'll get is, oh, a blue one or a red one. So it's important. So I always then have this in hand and say, can you actually point to the inhaler that you're using? So I can actually, and this has been helpful. And is available from the American Lung Association. Next slide. When we think about our approach to COPD, and this is a diagram that comes from Diana Stoltz et al. Paper, an excellent paper, that looked at our current approach to COPD that was published in Lancet in 2022. And this looks across several domains. It looks at, on the left-hand side, what are called idiotypes of COPD, which is basically the etiology of COPD that include, in most of high income countries, smoking is the predominant risk factor, but also there are other factors, including genetic factors, early life events, early life respiratory infections, and other environmental exposures. And then the middle column looks at the various endotypes or the really the mechanistic pathways to COPD, and then on the far right-hand side are the various phenotypes. And traditionally, these have included emphysema and chronic bronchitis, but certainly, and there are other sort of phenotypic characterizations, including, for example, we'll be talking about multimorbidities that I've been very interested in over the years, and other factors that also can be a guide to the more precise treatment of COPD. And in the latest gold revision, they actually enhanced the section looking at multimorbidity or polymorbidity, and this looks at the various components of multimorbidity, including that we'll be looking at in subsequent slides, and looking at various subdomains of this, but also looking at the importance of the various medications that patients are on, focusing on cognitive issues in patients, particularly as depression and anxiety, as these are important in our COPD patients, and the all important issues related to mobility and balance that are also important to our patients. And the major domains of morbidity, of comorbidities in COPD patients is noted on the right-hand side here. And these include cardiovascular disease, musculoskeletal disorders, including things such as osteoporosis and muscle wasting, endocrine and metabolic disorders, including diabetes, and then the neuropsychiatric disorders, predominantly anxiety and depression, that are very common in our COPD patients. Next slide. And certainly, as we've done a better job identifying, both these various endotypes and phenotypes, we have done a better job at characterizing patients better. Because on the far left-hand side, and I think this was the approach that we were using in COPD. When I started my practice now 35 years ago, where all patients were pretty much treated the same way. And in more recent years, we have better ways of characterizing patients. And as we'll be talking about later, we now have better, more targeted therapies to actually that hopefully will improve outcomes in certain subsets of these patients. And with that, I will pass this over to my colleague, Dr. Meredith McCormick.
Thanks, David. And so I'll pick up with our second objective to apply our case-based learning to think about risks of exacerbation and the implications of these. So we'll go to our next slide, and we'll go back to Martha. As we've met Martha, she's a 66-year-old woman who has a history of smoking. And since she was initially evaluated, she's quit smoking. And she quit smoking 2 years ago after she was seen for cough. And in the interim, she's been prescribed a short-acting beta agonist as well as a long-acting combination medication of antimuscarinic or therapy as well as a LABA or long-acting beta agonist after, as David described, she was confirmed to have airflow obstruction on spirometry. But 3 months ago, she had a moderate exacerbation that was treated with steroids and an antibiotic. And at that time, her maintenance medications were changed to triple therapy and an inhaled corticosteroid was added. But about a month ago, she was hospitalized for severe exacerbation. And at that time, during her hospitalization, she required oxygen, systemic steroids, and antibiotics. And now she's coming back for follow-up, and her labs are notable for an eosinophil count that's 200, so above 150 threshold that I sometimes apply. And we'll talk about the significance of this eosinophilia as we're thinking forward on how to optimize her therapy. Next slide, please. So just taking a step back, what are the implications of the fact that she's recently had a COPD exacerbation requiring hospitalization? And this is a really important part of her history and the history of our patients because hospitalizations for COPD exacerbations are associated with significantly increased risk of mortality and subsequent morbidity. And just highlighting a few data elements from studies that have really investigated what is the risk here and what is the magnitude of this risk. So, for example, we've seen that about 11% of patients with COPD die within 90 days of a hospital exacerbation, and that's been seen in a large retrospective study. And then if we extrapolate farther into the future, 50% of patients die within about 3.5 years after a first hospitalization for a COPD exacerbation. And these are again in large cohort studies. And we know that patients that have comorbidities, particularly cardiovascular comorbidities, are at an increased risk for COPD exacerbation, but also for cardiovascular events. And sometimes it can even be hard to tell whether a patient who has these types of comorbidities may be presenting with, for example, an episode of heart failure or is it a COPD exacerbation. But these patients with significant cardiovascular comorbidities are at increased risk of subsequent hospitalizations. Next slide. And so when we think about the cyclical nature of COPD exacerbations and how a current exacerbation increases risk for future exacerbations, I think the schematic can be helpful. And on the left, thinking about what are the drivers of exacerbations. So right now we're in the middle of respiratory virus season. So viruses are certainly a strong driver, as are bacterial infections. But there are other factors that can influence our patients, including episodes of air pollution or proximity to air pollution, and probably other environmental factors that may be less obvious, including allergens. When we think about the interplay between infections, pollution, environmental exposures, we know that from a pathway or mechanistic standpoint, these can increase in inflammation as well as increase physiologic impacts on the airways, including bronchoconstriction. And when we have worsening airflow, worsening flow limitation, we have worsening VQ mismatch, which can lead to hypoxemia, air trapping, increased symptoms, and also can cause stress on the heart and exacerbate those comorbidities. So in the recent GOLD guideline update, we see this figure here, which is approaching classification of COPD exacerbations. And so this is a schematic that shows the Rome classification criteria that really represents a shift to looking at a patient prospectively when they're entering an exacerbation and classifying in that way, rather than retrospectively looking at how much medication they required or where they ended up. This is something that can be practically applied to our patients and is really based on symptomatic and data that we might have based on our physical exam or studies that we're ordering at a time of presentation. So we see mild, moderate, and severe, and factors like dyspnea, heart rate, respiratory rate, pulse oximetry, blood gases, and the like being integrated into this classification scheme. And again, we'll go back to our case as well as this idea of etiotypes, endotypes, and phenotypes with an emphasis on recent approaches that are now available for our patients with COPD, focused on eosinophilic inflammation, which we can get from the widely available CBC with differential, and how that relates to risk of exacerbations as well as potential therapies. Next slide. So when we think about approaching the patient in front of us, this is again another figure from the updated GOLD guidelines. And here with our case of Martha, where she's in our office in our clinic after coming in from an exacerbation, and now we'll review her symptoms. We have a recent exacerbation and reconsider whether we have her on optimal therapy. David showed that schematic of the different inhalers and therapies that are available now. And that's really a tool I use very widely in clinical practice. Every patient that comes in, I ask them to point out their inhalers. And that's also a nice time to review technique and get a sense of the confidence that an individual has. And if you have the availability in your practice to actually have them show you how you use their inhaler, that's strongly recommended because we know inhaler technique and adherence is a really important aspect of care. And so here, again, taking our algorithm from the GOLD guidelines and thinking about what to do with our patient now that she's been hospitalized for an exacerbation while on LABA, LAMA, ICS triple therapy, we use and we'll use our eosinophils to guide how we might consider different approaches. But we see the availability of roflumilast, azithromycin, as well as newly available biologics for patients with COPD. And so as we're transitioning to thinking about the role of T2 inflammation and how we might revisit this in terms of therapeutic options, I'll turn it over to David to talk more about T2 inflammation.
Thank you, Meredith. And so if you want to the next slide. And we talk about various types of inflammation. You might hear that the terms T1, T2, or type 1, type 2, type 3. With type 2 being mostly the more allergic or eosinophilic type of inflammation. Type 1 and 3 being more neutrophilic driven, and we don't have sort of targeted therapies in that space yet, but we do have now targeted therapies in type 2 inflammation. Several slides back, Meredith showed you a slide that looked at environmental exposures or things such as viral infections and how they led to inflammation that then related to outcomes such as COPD exacerbations. And this now provides a little bit more detail in that, up at the top, you have basically an airway that is exposed to something in the environment as infections or pollutants or allergens, which then in susceptible patients can initiate a cascade of events that ultimately results in activation of various interleukins, and the ones that we now have targeted therapies for are noted here: interleukin 4 and 13, along with interleukin 5, and as these inflammatory pathways are activated, it causes a number of downstream events that are noted here, including, as noted, changes in smooth muscle, fibrosis, mucus hypersecretion, mucus plugging, along with setting up a cycle of increasing numbers of eosinophils that can then activate the cycle even further. And with the end result being, airway obstruction, airway hyperreactivity, and exacerbation events. So anything that can be done in these susceptible patients to interrupt, this pathway, either by decreasing exposure to allergens or pollutants up above, or interrupting the pathways with therapies is key. And that then brings us to our newly approved COPD therapies. Ensifentrine actually was approved in June of 2024, and this is a phosphodiesterase 3 and 4 inhaled therapy that targets a different pathway than what we're talking about today. Dupilumab, that was approved in September of 24, targets IL-4 and 13 pathways, and mepolizumab, which has been available for the treatment of asthma for several years, as was also true for dupilumab, was approved for COPD with an eosinophilic phenotype in May of 2025. And some of the rationale for that is noted in this slide, and this is work done by Mona Bathadel. And this demonstrates, at least and these were trials that were looking at therapy using the inhaled steroids in the treatment of COPD, and found that that eosinophil counts were in fact a biomarker of sorts for a response to therapy. If you look, for example, at that slide down the bottom, or the section down the bottom, that patients with higher eosinophil counts, if they were on not on an ICS-containing therapy, if they were on just formoterol alone, the higher their eosinophil count was measured at baseline, the more exacerbations they had. Whereas that same a similar patient with a higher eosinophil count who is on an inhaled steroid, that of budesonide, that relationship between eosinophil count and exacerbation rate was extinguished. And this provides benefit. And then you see the reverse when you look at lung function, although it's not nearly as impressive as the change in exacerbations. And this demonstrates that eosinophils are in fact a type of biomarker for response to therapy in COPD. And this all then was used to help design clinical trials that Meredith will be talking about in the subsequent section. Well, and this might be an opportunity, at least a question that has emerged or that has popped up is, how does one obtain a true baseline of eosinophil count in patients who have already received systemic steroids in the hospital? And okay, here's our slides again.
Yeah, I think that's such an important point. Go ahead, David. What were you going to say?
Yeah. Well, I think that's an important question because steroids will decrease eosinophil counts, and I think that's why it's at least when I look at this, I like to look at unfortunately now with our electronic medical record, you could see eosinophil counts at over a period of time, so you don't have to rely on just sort of one point in time, but certainly I think it's worthwhile, looking at all the data one has available. And also, when I talk to patients and think about these types of therapies, I like to consider other sort of asthmatic, what I call asthmatic-like features, where patients who have they clearly have COPD, but if they have a lot of variability in their symptoms, or if they had a history of asthma as a child, or if they have a large response to a bronchodilator, that at least sort of leads me in the direction that this might be a person who would be more responsive to inhaled steroids or potentially biologics.
In the next section will be to define the clinical implications of COPD heterogeneity, thinking about things like frequent exacerbator subtype, chronic bronchitic emphysematous subtypes, and think about how we might apply biologics as therapies in COPD. And I'll be reviewing some of our recently published clinical trials from the last several years, investigating the role of biologic therapy in patients with COPD. And so again, to review some of the recently published clinical trials, these are studies that were published in the last 2 years. Surya Bhatt and colleagues in both the New England Journal of Medicine as well as Lancet Respiratory Medicine, reporting on the results of the Boreas and the Notice trials. Both of these studies were large randomized double-blind placebo-controlled studies of individuals on therapy for COPD who had greater than 300 eosinophil count. And here we see the top-line results on the left of the Boreas study, which demonstrated that individuals randomized to dupilumab sustained an improvement in moderate to severe COPD exacerbations with a significantly reduced risk of COPD exacerbations. And on the right, you see pooled data from both the Boreas and the Notice that had similar study designs. And we see, again, the confirmatory result that the individuals randomized to dupilumab had a reduced risk of COPD exacerbations, and both of these studies going up to 52 weeks. In the Boreas study, studying the impact of dupilumab, we also saw benefits in terms of lung function, which is shown here on the left. So pre-bronchodilator FEV1 improved in the group randomized to dupilumab, as well as improvement in respiratory status, here indicated by the St. George's Respiratory Questionnaire score on the right. And there we see a favorable result showing improved respiratory status among individuals randomized to the dupilumab therapy. So other studies that have looked at the role of biologics in COPD, these are clinical trials that studied the role of mepolizumab in COPD, the METREX and the METRIO studies. While we looked at the prior studies showed that individuals with COPD who had an eosinophil count of 300 were the study population. In the METREX study, they looked at a subgroup analysis of individuals who had greater than 150 at entry or greater than 300 in the past year. So looking back to the past year, and among that group, individuals who were randomized to mepolizumab compared to placebo fared better in terms of risk of moderate to severe exacerbations, the primary endpoint, with an 18 to 20% reduced risk. On the right, we see the results of the METRIO study, which did not find the primary endpoint there, also of moderate to severe exacerbations, did not demonstrate a difference between mepolizumab and placebo. In this study, they looked at both the 100 milligram and the 300 milligram dose and did not find a benefit of the 300 milligram dose, suggesting potentially a threshold of benefit that 100 milligrams was basically enough to achieve the benefit that they saw in METREX, and that there was no additional benefit to be gained by 300. Again, the METRIO study, though, did not meet the primary endpoint. This was not a statistically significant difference between the mepolizumab and the placebo group. In this follow-up study, MATINEE, again studying the role of mepolizumab in COPD, here the study criteria was eosinophil count greater than 300 among individuals with COPD. And the participants, as in the prior studies, could have chronic bronchitis or not. It wasn't limited to those with chronic cough or chronic bronchitis. And the MATINEE study followed individuals out beyond that 52-week to over 100-week study duration. And here again, we see a benefit in terms of the reduced risk of moderate to severe exacerbations among those randomized to the mepolizumab group. So really, when we think about in total, we've just seen two different medications targeting different pathways for eosinophilic inflammation or type 2 inflammation, both with impact on moderate to severe exacerbations, which, as we've talked about during this presentation, really are important to individuals' quality of life as well as the risk of subsequent adverse health impacts. Next slide. In the MATINEE study investigating mepolizumab and COPD, we did not see improvement between the intervention, the mepolizumab or the placebo group, in either the CAT symptom score on the left or in lung function, shown here on the right. So when we think about Martha and patients like Martha who have had a severe exacerbation, who have been hospitalized, I think the results that I just showed you really, in my mind, are exciting to think about new therapies that we have for patients with COPD who might be the right subgroup most likely to benefit. And we can think together about how we might use biomarkers and endotyping to try to really identify those that are at the greatest potential to benefit from these therapies, and how we apply that evidence from clinical trials to the patients in front of us. I think the next steps that Martha has in follow-up really are important points as we think about all of the dimensions of caring for patients with COPD. And so we can talk about those. But I thought maybe I'd pause because the question that we were just answering from the Q&A, as well as this patient who has an eosinophil count around 200, I think is a good point to talk about how we might approach patients and how we apply evidence in the real world. And I would say that to the point that was raised in the question and answer, when I have a patient in front of me and they have an eosinophil count of 200, I really like to look back at their prior records. And hopefully a lot of that information is in my electronic health record where I can look back easily. But if it's not, I do go to the length of looking in different tabs or trying to understand if in my electronic health record, going to the media tab to look at outside records to understand their trajectory. And I think the more evidence I have that someone has had higher eosinophil counts in the last year over the course of time is important to understand whether they are more of a T2 phenotype and or whether they have eosinophilia that tracks with their disease course and is a target that is treatable now with these newly approved therapies. Um, David, I don't
Yeah,
know if you have any comment about how you approach that.
well, yeah, I agree with you 100%. And also, in some of the other points in here, I think for the first point about her being exacerbation free, and that is so critical
Yes.
because, as we point out, each exacerbation, and I explain to patients, has the potential to put you in the hospital and frankly end your life. So our goal is always zero, and I stress that to patients. Uh, for people that patients that continue to have persistent cough, and I think we always have to sort of be on alert to look for other things. And for most cough in our patient population, it is related to things such as, well, we see it as part of chronic bronchitis, but be sure that you're not dealing with the medication issue. Um, medications like lisinopril, captopril, so that's something that, if a patient is on that and they continue to have these sort of nagging cough, I have the discussion with their primary care provider to see if we can look at that. With the question about inhalers. She certainly should continue her maintenance inhalers. If she can, decrease or eliminate the use of her rescue inhalers or nebulizers, I think that's, always important. I'm a big fan of using, rescue inhalers or rescue nebulizers as little as possible because I am concerned about the cardiac effects related to those. And I think that's an area that, we're actively sort of, researching. And pulmonary rehabilitation is so very important in this patient population. And I think every patient that I've sent to pulmonary rehab, comes out far better after having completed that. So I think that would be a critical intervention in her case.
I completely agree, especially those last 2 points for the continuing of inhalers. If I'm starting another therapy, whether it's azithro, roflumilast, ensifentrine, or now the biologics, I think that educational piece is really important, and that's something I've really learned over time as more therapies have become available, is to make sure to really go back to that foundational to make sure that those maintenance inhalers aren't dropping off either because of cost, because of just not having that integrated into the routine or the desire to minimize medications, but really having that discussion, I think, has been important, especially with biologics, making sure that that doesn't get lost. And rehab, I think, is another area with the advent of virtual rehab and maybe having more platforms to engage patients. I think that's something that we're starting to see more in clinical practice, and possibly, I think will be likely that we'll see more in the future, thinking about different ways to get rehab and access to rehab for our patients because we still have pretty long wait times at some of the rehabs that are local to where an individual may live. And so I think we see really many different ways that we can try to understand actionable points where we can improve health of the individuals of our patients. Eosinophilic inflammation being just one that has a lot of promise. But I think as we learn more and as we think about different ways to endotype patients, we'll have more precision medicine approaches moving forward. Next slide, please. And so back to our patient, I think we have several options that we could offer. with advanced therapies, and that I think an important point is having had an exacerbation, now having a hospitalization, this is really the time to act. And so I think even when patients are in the hospital or making that transition, it's a really important point to stop it and realize that this is an indication for thinking about additional therapies. And so, really, I think we've emphasized that COPD is heterogeneous, and people with that meet the frequent exacerbator or the severe exacerbation phenotype are at high risk for subsequent health consequences. And that's a really important time to intervene. And as we think about treatable traits and the ability to apply more precision medicine approaches and personalized therapies, I think it's a very exciting time in COPD that we have new therapies that are available. And today we've really shown a spotlight on eosinophils as a biomarker that's readily available in routine clinical practice and can help identify those more likely to benefit from specific therapies, including the two newer agents, dupilumab and mepolizumab, that now have indications for COPD. I think we can
Great.
open it up to any comment that you have, David, as well as our question and answer. I'm actually having trouble seeing the question and answer,
Well,
so
I can access them, so I'll,
perfect.
yeah, yeah, we already addressed the first one. Yes, another question comes in is, in 2026 GOLD, are inhaled corticosteroids no longer recommended for stage E without eosinophilic inflammation? And should we do the other options, azithromycin or flumilast? And should we stick with 300? Well, inhaled steroids are still recommended in that group E patients, so that yeah, exacerbating COPD patients. I think the question is, and certainly above 300, there seems to be no sort of question. In that 1 to 300 range, I still use that use inhaled steroids in that group. And the question comes in is, well, what about that person that's below 100? Are inhaled steroids perhaps doing more harm than good in that patient population? And I haven't seen an actual study that addresses that. And what we've seen are, when you sort of, I think one of the diagram I showed you from that Mona Bathadel's paper, that it seems like once you get below 100, that that benefit of inhaled steroids may not be there. But again, and the number of patients in that, at least in those trials, is relatively small, and I think that might be a rationale for not using inhaled steroids and perhaps considering a azithromycin over flumilast. But if I have an exacerbating patient, even with low eosinophil count, if they've not had pneumonia, I'm probably going to treat them with inhaled steroid, at least initially. And Meredith, what's your thought process there?
Yeah, I think you key down on something that I really look for is whether someone has a risk factor for infection or has a history of pneumonia. And then otherwise, I think for those, especially for having exacerbations or for having that evidence of allergic inflammation, those are some areas that I look to try to help guide.
Yeah, and certainly in my patient population, if exacerbating COPD patients are almost always on either azithromycin, which I typically are using it 3 days a week, or roflumilast, sometimes both, and if patients can tolerate it, and of course, with and they're and with both of those therapies, there are things you have to look for, side effects with roflumilast and with azithromycin, things related to your hearing and potential cardiovascular
I was going to ask you about
effects.
hearing and how you approach azithromycin because that is something that
Yeah,
is
I
important not to overlook, especially in a
yeah.
population that might be enriched for baseline
Yeah,
hearing.
I inform patients about it, and unfortunately, I haven't had an issue in my patient population, but certainly it's been reported, and I've heard from others. Um, uh, but yeah, a lot of my patients start out with hearing issues anyway,
Yeah.
so it's um, uh, But yeah,
That's been my approach too, is to really talk to patients about it and then think about how you assess from there based
yeah.
on that conversation.
And the next question is, can we start biologic therapy after recurrent exacerbations in patients with variable eosinophil counts, even if elevated eosinophils are not consistently documented? Um, and, and again, and a lot of this is going to be related to what right, various criteria payers are an important sort of part of this mix have required for for and in our clinic, when we put somebody on a biologic, I sort of talk to our in-clinic pharmacist that we're fortunate to have, and say what do we need to make this happen, and depending on the payer, sometimes you have a 6 month look back or a 1 year look back, and if they sort of meet a criteria at any of those times, would qualify. Has that been your experience, Meredith?
That's exactly right. I think looking back and then making the case for to justify the use of the medication, and then seeing about getting prior auth and approval. But generally, I think having a look back where you see evidence of eosinophilia, even if it's not on the day, is important. The other thing too is sometimes patients either take steroids intermittently, and trying to understand whether the history of eosinophilic inflammation ties to steroid use that might be happening in the background can also be important, because if there's not persistent or consistent eosinophilia, it's also can be helpful to know if that might be driven, the suppression might be driven by steroid use.
Yeah, correct. And I've been a part of a couple of several different projects and papers, looking exactly at that, the variability of eosinophil counts, and certainly in clinical databases, and people don't get CBCs with eosinophil counts randomly. They typically are linked to some type of event. So it's always so what you see there is a little bit different from what you see like in a sort of a more of a population-based, study, or like follow-up of COPD gene or one of these other big studies. I think we sort of addressed this. What selection criteria are used for selecting biologic or for using biologic therapy? And it's right now it's both exacerbation and eosinophil count is the main driver. I don't that may change in the future. It's an interesting question, Meredith. If inflammation is also the underpinning of cardiovascular disease and COPD, um, should we add anti-inflammatories for stage A and B also, roflumilast, inhaled steroids, or others? Is there any evidence for reduction in cardiovascular risk with these medications? I'm not sure if LAMAs have that much anti-inflammatory impact. That's actually, Meredith and I had that discussion before we got on today. Yeah, that is a great question, and it's sort of been the focus. There was a study several years back that was called StatCope that was looking at the role of statins in COPD, for patients who otherwise didn't qualify for statins. That didn't quite, you know, it didn't show a benefit, although they went through great pains to exclude anybody that may have, qualified for a statin. But I think that's that's actually something that I'm very interested in also. And Meredith, what are your thoughts there?
Yeah, I think that these are a fascinating set of questions that hopefully, as we're moving forward, we have data, electronic health record data, and other types of data, we can look at. I think one way to think about it is co-benefits. Are there co-benefits in terms of medications we use that we don't always study in COPD trials? We study COPD outcomes, and cardiovascular trials we study cardiovascular outcomes, and sometimes we exclude the opposite group. And so the ability to look at to assess the impact on multimorbidity by looking at potentially co-benefits of outcomes. There may be, new different approaches we can use in the future in looking at data at scale. That
Yeah,
I think these are great set of questions
yeah.
to think
In
about.
fact, I've been talking with Mona Bathdal. She did a study called ABRA that looked at biologic therapy. post-exacerbation event. But I was interested because one of the if one thinks about what happens after COPD exacerbation, hospitalized, the risk of cardiovascular events skyrockets.
Yeah.
I always wondered how much of that is related to people using a lot of these short-acting agents, all of which are 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 are, are cardiostimulatory,
Yeah.
beta agonist. And if in fact, one can reduce beta agonist use, with a biologic, might that be a benefit? I think that's something, worth, uh, investigating. Another question: how long can biologic agents be used? Well, we don't have that study yet, but right now and certainly, well, I guess we have more of an answer in the asthma world um, um, where at least, some patients have been on it long enough where their condition has stabilized and they're actually, now coming off of that, or at least they're increasing the interval between dosages. No data like that in the COPD world yet, but certainly, I've had and I hear from patients who have been on, one type of therapy, have not really felt like they have had a good response to it, and either have stopped or changed to another one. Um, um, but there's no real. I haven't seen data at
Yeah.
least in the COPD space on that yet.
Yeah, I think it'll be very interesting to follow individuals longer. And I mean, we have trials that have extended out with matinee going beyond the year mark. But as we're following patients on it, I think as we've seen in asthma, um, that next set of questions about duration of therapy and potentially, benefit beyond stopping therapy, these will
Yeah.
be important questions to think about.
Yeah. There's another interesting question. Could COPD phenotype without initial eosinophilia evolve into a type 2 type? And if so, is there a specific trigger? That sounds like a research question to me. Um, I and one would think that there is some sort of stability around these sort of endotypes, but there may not be. And certainly, and we've had, for example, in the asthma world, adult onset asthma is a real thing, and there are triggers where that sort of drive people, down that pathway. I don't see why that might not be the case in COPD, but I think that's a great research
Yeah, I've
question.
asked that question on an individual basis when I've looked at patients who somehow, all of a sudden you get this eosinophil count of 600 and then you get some that are 300 and
Uh,
it just sort of starts at some, in some year of time. And in those cases, I ask about things like moving or extensive traveling or, changing homes or, is there something in the environment that might be driving an allergic response that wasn't there before? I find that infrequent that happens, but I have had a few instances where I thought it was curious that you see this signal pop up where it wasn't there before. I think also it depending on what type of patient, if it's someone who's very severe, just understanding the background of prednisone use or steroid use can be important as well.
right. I think we have time for a couple more questions. Um, one question is there harm from people quietly discontinuing inhalers because of the inhaled steroid experience? Um, More harm than that from the actual inhaled steroid. Yeah, certainly there are some patients who, because of side effects from inhaled steroids, things like thrush, or if they have had sort of an infection or pneumonia, um, that they may stop them. And yeah, and there's potential harm from that, but there's also potential harm in some patients, from inhaled steroids. And I think that's why it's great to have additional options. And I always have, um, um, when I'm interviewing patients, particularly in follow-up, you know, I, s- I always want them to be as honest, honest with me. It's like, what actually are you actually doing?
Yeah.
Because if and some patients, they'll be right up front. It's like, yeah, I'm not using this. I didn't notice any difference, and so we sort of go from there. The Another interesting question. Given recent studies showing withdrawal of inhaled steroids in COPD patients can lead to increased exacerbations, and we saw that, for example, from studies such as Impact. Do you think initiating biologic therapies could help prevent exacerbations while reducing the risk of ICS-associated pneumonia? I think that sounds like another great research question, and certainly I think one of the holy grails in the world of medicine in general and pulmonary medicine in particular is finding something that gives one the benefit of systemic steroids without all the side effects. And you can say the same for inhaled steroids, and you can see that across the world of medicine. That's why you see better treatments now for inflammatory bowel disease and collagen vascular disease. Um, so so yeah, I think that's a fair question. I think for a final question that we can address, because we're almost out of time, is how does one choose between the two available biologics? That's What's your answer, Meredith?
Yeah, I think, well, in one way can also be to look at co-indications. So if somebody has another comorbidity that's treated by one of the biologics, that can be that's not as frequent, but that can help drive that decision. Um, Sometimes it's in practice. Sometimes it's related to if there's a difference between what your insurance company will cover. Sometimes there is a preferred one versus the other. So that's just a practicality. Um,
Yeah.
I don't know if you would have any other comments, David.
Oh yeah, and my initial patients on biologics actually were on there because of sinus related
Yeah,
indications. So and they had a great response and their lung disease improved.
yeah,
So that worked out well. And I think there are other and currently we have a Q 2 week injection as opposed to a Q 4 week injection. So
that's
that
a good point
might
too.
be a difference for some patients. And I think we are. Um, and they're going to be, and there are other sort of therapies in development that are even looking at longer intervals. So, so I think there's, uh, but I think the main thing, as you mentioned, is going to be what their what their coverage is, and in terms of co-pays and what various hoops are needed to jump through to get these therapies. And I think
Which
with
I
that
think
we
is
are.
just an important point in general is talking to patients about cost of medications, including inhalers, because
Right.
just like you mentioned, just having that honest conversation, understanding what people are really doing, what medicines
Yeah.
they're really taking, and
Yeah.
cost can be a barrier. So it's an important
Yeah.
one to address.
And particularly this time of year, because when January comes, that's when the clock starts again for people that are on Medicare with co-pays,
Yeah.
and and we're seeing on social people talking about, oh, now my inhaler costs $500, and it's like, well, a lot of that's related to the copay
Yeah.
and that they haven't fulfilled that yet. Although now with Medicare, there are options to actually spread that copay out over the entire year as opposed to doing it all up front. And I think we are now at the top of the hour. So I apologize for any questions that we are not able to address. But thank you all for your time and attention
Thanks for the
and some
great
great
questions.
questions.